This video is on the menstrual cycle. Once a lady hits reproductive age, then every month they'll produce an egg and also prepare their uterus for pregnancy. Let's see how both those work. We'll start with the egg first. So in your ovaries, you have a bunch of eggs or oocytes. And surrounding your oocytes, you have support cells like theca cells and granulosa cells. And that whole structure we call a follicle. In the beginning of the cycle, your follicle will start to grow bigger and bigger until there's one dominant follicle, and that follicle will erupt and the egg will be released. The rest of the complex becomes your corpus luteum. So corpus luteum. That is the egg part. Now how about your uterus? Do you remember the functional layer of your uterus? That'd be your endometrium. Well, the menstrual cycle also prepares your uterus, your endometrium, for pregnancy. It'll grow the endometrium, or we call that proliferate. And not only will the endometrium proliferate, but it'll start to grow vascular. And it'll start to have many vesicles, start to secrete things. So we call that secretory. And that's how your body prepares your uterus for implantation. Now if a sperm goes into the egg and fertilizes it, it can implant and you have pregnancy. If that doesn't happen, then your egg will degenerate and your endometrium will degenerate and it'll slough off, and we call that menstruation. After which your body will start to cycle all over again. That is your menstrual cycle. Let's look at it in a little more detail. We'll start with the egg. So the creation of follicles occur when girls are fetuses. However, it's important to note that these stay in prophase 1 of meiosis. Very important you know that. However, they'll start to grow until one dominant follicle is made, and that is released. And only after release or ovulation, does it continue on its cycle into metaphase 2. So it completes meiosis 1, starts meiosis 2, and stops at metaphase 2. And lastly, once it gets fertilized by a sperm, it'll finish meiosis. You absolutely need to know all these stages. This has been asked many times before, so it's not a smooth continuation of meiosis. They'll start, stop, and you need to know when they start and when they stop. So when you start making follicles, they'll stop at prophase 1. After ovulation, they'll stop at metaphase 2. So this follicle is at metaphase 2. And then only after fertilization do they fully finish meiosis. Important that you know that. All these follicles will start to make estrogen. We talked a lot about estrogen in our previous video. What do you think estrogen does? Doesn't it proliferate your endometrium? And that's how they're linked together. And you ovulate, release that egg. So you have your egg, and then you have the remnants of the follicle, which is your corpus luteum. Your corpus luteum produces estrogen. It also produces something called progesterone. And progesterone is the most important hormone in changing your endothelium and making it possible for pregnancy. It's good that you proliferated it, but now you have to make it suitable for pregnancy. Make it secretory, make it vascularized. And your corpus luteum and progesterone is what does that. That's how these two are linked. One last thing it produces is something called inhibin. We'll talk about what that is shortly. That is your cycle. Sometimes we like to break it up in halves. So this half is sometimes called the follicular phase because you're making follicles, or sometimes it's called the proliferative phase because you're proliferating the endometrium. This half is sometimes called the luteal phase because it has a lot to do with the corpus luteum. Sometimes it's called the secretory phase because your endothelium is becoming secretory. That's just some terminology. Hope that helps. It's quite a complex cycle. How does your body mediate all that? Well, it does that through, what do you guess, hormones. The big one is GnRH, or gonadotropin releasing hormone. This is what starts menstrual periods in the first place. Recall when you're younger, you have this low basal level of gonadotropin releasing hormone, and then something changes and it starts becoming pulsatile. And that pulsatility is what starts your menstruation. That's what starts menarche. And GnRH controls two hormones. And surprise, surprise, they correspond with the stages of their menstrual cycle. So the first one is called follicle stimulating hormone. That stimulates the follicle, causes it to grow. That causes it to release estrogen and proliferates your endometrium. That's the first half. The other one is called luteinizing hormone for luteum, luteinizing hormone for luteum. That causes you to ovulate, release that egg, but more importantly, turn the rest of that complex into your corpus luteum. And that corpus luteum makes progesterone, starts the second half of your cycle. Understand, that is GnRH. That is how your cycle is controlled, grossly. But a lot of times they want you to know what happens at a hormonal level. You may have seen pictures or diagrams of the hormone changes. I've been asked many questions on that before, so let's see if we can decipher what goes on. So we'll start with GnRH. Again, that's what creates the menstrual cycle, menarche in the first place. It releases a pretty equal amount of FSH and LH. So we'll say it looks like this. This is FSH. This is LH. Let's follow FSH first. That stimulates your follicles to grow, and as your follicles grow, they'll produce estrogen. So this will be estrogen. Start to grow, produce estrogen. And estrogen does something very, very special. At regular low levels, estrogen will start to suppress FSH, LH via negative feedback. But then at higher levels, as this follicle keeps growing, as it keeps producing estrogen will continue to rise. And that negative feedback turns into a positive feedback, namely a positive feedback on LH, and it causes LH to explode. The exact mechanism of why it turns from negative feedback to positive feedback is not that clear. Maybe it affects GnRH pulsatility, favoring LH. Maybe it starts working on different neurons in the brain, changing its negative feedback to positive feedback. But the most important thing you need to know is that LH surges. And what did we say LH did? LH causes ovulation because it needs to make that corpus luteum. Yeah? So it surges, causes that ovulation, causes you to release that egg and make that corpus luteum. Now estrogen will start to decrease, but at this time, because you've made your corpus luteum, another important hormone comes into play. That is your progesterone. Made from your corpus luteum. Your corpus luteum also makes estrogen, so estrogen will take a slight raise. And it also makes inhibin. Inhibin blocks your GnRH. So all right, inhibin blocks GnRH. That will lower your LH and your FSH. And the reason it does that is it doesn't want you to make more follicles, doesn't want you to release more stuff, because it wants you to focus on your cycle right now, not create another cycle while you're having a cycle. That'd be a nightmare. So inhibin blocks GnRH, stops another cycle from happening, and that is graphically or visually what your hormones look like during your menstrual cycle. I've seen questions where they don't even label this. or any of these, and they'll just point to one of them and say, what is this? And you're like, you have to figure it out. Oh, this is estrogen because it rises and causes the LH surge, and it also rises back up after the corpus luteum, creates more estrogen. Or the easiest one is if they just point to the LH surge. That's a no-brainer. If pregnancy doesn't occur, your egg degenerates, your corpus luteum degenerates. Inhibin goes down, no longer blocks Gnrh, and then you can start a new cycle. And that would be your menstrual cycle. That was your cycle. Let's talk about disorders of the menstrual cycle. You can have really painful cycles. We call that dysmenorrhea. You can have very heavy bleeding. We call that menorrhagia. You can have anovulation. Where you don't ovulate and you don't menstruate or have your period. And the biggest cause of this is just pregnancy. Always rule this out in a patient with anovulation. I've seen questions where they'll talk about a patient with anovulation. What is the next thing you'll do? You do a pregnancy test. Other causes include things like PCOS. We talked about that. You can suppress your GnRH if you lose too much weight or if you exercise too much. It basically tells your body you're calorie deficient or you have too low body fat to have a baby. So exercise or weight loss, stress can also do this. So these cause a problem because during our first phase, we proliferate our endometrium. And during our second phase, we make it secretory, make it suitable for implantation. And if it doesn't, we shed that endometrium. If you have anovulatory cycles, then you proliferate the endometrium, but you never shed it. So your endometrium grows and grows and grows, and you can get hyperplasia, and hyperplasia can lead to endometrial cancer. So these patients are at increased risk of hyperplasia, and the worst of all, cancer. There's also another thing that can cause anovulation, and that is Asherman Syndrome. Let's draw back out so you proliferate and then you make it secretory and vascular, etc. And if there's no implantation, you shed, and that's your period, right? Well, after you shed, how do you start the cycle over again? Well, at the bottom of your endometrium, you have a basal layer. That's where all your stem cells are, and those stem cells will start to proliferate, and you'll start your cycle back over. Asherman syndrome is when you destroy that basal layer, destroy your stem cells. So destroy basal layer. How do you do that? Well, you can have uterine procedures that just scrape and destroy your stem cells. Things like dilation and carotiding, which basically dilate your cervix, put something in, and then scrape your endometrium. And they do that for things like miscarriages, and they need to get all the fetal and placental parts out. So they put in something to scrape everything out. And if they scrape too hard, they can damage the basal layer, and you get Asherman syndrome. How can you tell when you have a regular endometrium that's just not shedding, or when you just have a destroyed endometrium and that's why you're not having cycles? We can do the Progesterone Challenge. Recall, the first half of the cycle is estrogen dependent. That's what causes the proliferation. The second half is progesterone. That's what makes it secretory vascular. And then eventually if you withdraw the progesterone, it will cause it to shed. So the progesterone challenge is you give a patient who's having anovulation progesterone, and if they have a normal endometrium, then giving that progesterone will cause it to turn secretory vascularized. Then after that progesterone is gone, they will shed. They will have a period. Yeah. In a patient whose endometrium is destroyed, you'll give them that progesterone and nothing will happen. They won't have their period because there's no growing, there's no shedding, there's nothing, because their endometrium is shot, basically. That is the progesterone challenge. So all those things we talked about warrant investigations. But let's say a patient's been having anovulation, amenorrhea for a long time, and the patient is older, let's say around 50, then what are you thinking? Then you might be thinking of something, a more natural process. Then you might be thinking of things like menopause. Menopause is amenorrhea for over 12 months. And that occurs usually when a patient's 50, around 51. Sometimes it can be earlier, sometimes it can be later. Things that make it earlier are things like smoking, but an earlier menopause can be normal. So in menopause, you basically run out of follicles. You have a limited amount of follicles, and as you get older and older, you start to run out. Because you run out of follicles, your estrogen decreases. That loses that negative feedback to your GnRH, to your brain, causes a raise in GnRH and FSH, LH, and you can actually see these on laboratory. If you need to confirm menopause for whatever reason, you want labs to do it, then you'd see that it's decreased estrogen, increased FSH, LH. What happens when you have decreased estrogen? Well, a rapid decrease in estrogen causes increased norepi and serotonin, and that can cause changes in your thermal regulation, give you hot flashes. Hot flashes. Your reproductive system responds to estrogen, does it not? And when you have a decrease in estrogen, they can start to atrophy. One of the main parts is your vagina. So you get atrophic vaginitis, can appear as pain, can appear as pain on intercourse, drying, atrophy, that's atrophic vaginitis. And then lastly, remember estrogen has many roles. Estrogen raises HDL, that's your good cholesterol. So when you have a decrease in estrogen, then you'll have decrease in HDL. That gives you bigger chance of CVS disease, cardiovascular disease. Estrogen also binds and inhibits osteoclast. And so when you go into menopause and you lose estrogen, you can have osteoporosis, or at least an increased risk of osteoporosis. So these are common symptoms of menopause, or sometimes even perimenopause. That's the period right before menopause. So notice, again, it normally occurs around 50-ish. If it occurs earlier, if it occurs in patients earlier than 40, then we're suspicious there might be something wrong with the follicles, with the eggs. This can occur if there's damage to your follicles. So chemo can do it, radiation can do it. You can have surgery where you have to take out an ovary for whatever reason. You can have abnormal ovaries, like in Turner's. So we talked about chemo, radiation, surgery. All those things can decrease your follicle count, eventually leading into early menopause. We call that premature ovarian failure. And the name gives it away. Premature ovarian failure. I want to finish this video with a talk on pharmacology. In this video, we talked about a lot of hormones like Gnrh, estrogen, progesterone. Well, we've discovered we can manipulate these hormones to benefit our patients. We'll start with Gnrh. For example, we can give synthetic Gnrh. We call that leuprolide. Now recall normal Gnrh, before you start your menstrual cycle, it's at a basal layer. So this is non-ovulatory. But then once you start menarche, once you start making cycles, it becomes pulsatile. So we'll just say menstrual or menarche. By knowing this, we can manipulate it to our benefit. If we want to give leuprolide in a basal layer, we can do that to suppress the cycle. By suppressing the cycle, we can lessen symptoms of things that respond to cycles like endometriosis, adenomyosis, things like that. Or we can give leuprolide in a pulsatile manner and cause ovulation. We do that if we want to increase fertility. So if a patient's not really having their cycle, we can synthetically control it for them. That's leuprolide. Side effects of leuprolide is nausea and vomiting. Those are common side effects. SE stands for side effects. If you see that in my notes and don't know what that means, it means side effects. Another drug I want to talk about is Clomiphene. Very common drug. Clomiphene or Clomiphene, binds estrogen receptors, but it doesn't activate them. It just sits on them. And by doing that, your body thinks you have a low amount of estrogen. It binds those receptors, but doesn't activate them. And because it thinks you have a low amount of estrogen, it increases your Gnrh, eventually FSH and LH, and that causes you to ovulate. This is a fertility drug used to increase fertility. Side effects are multiple gestation. It can work a little too well, so you can have twins and triplets, etc. And one of the main ones you should know is it can cause visual defects. As minor as blurry vision, as serious as permanent eye or vision loss, so know that well. How it causes that, I'm not too sure, but visual defects has appeared in a lot of questions before. A drug very similar to Clomiphene, and is not used much anymore, is danazol. Danazol is a synthetic androgen that binds androgen receptors and also binds estrogen receptors. However, this, unlike Clomiphene, does activate your estrogen receptors, and your body senses that, oh no, we have too much estrogen, and it decreases Gnrh. This suppresses your cycle again for things like endometriosis, adenomyosis, etc. However, the side effects were too great, and this has pretty much been replaced by leuprolide. Side effects include hirsutism, because it is an androgen. It was hepatotoxic. It still finds its use in a very particular case, and that is hereditary angioedema. Hereditary angioedema, if you recall from our immune block, that's when you can't break down complement. Complements are inflammatory mediators. It causes chemotaxis of cells, causes swelling. Angioedema if you have too much complements. For some reason, danazol increases complement inhibitors, so you can lower the amount of complements. Lower complements by increasing complement inhibitors. So just notice kind of a historic use for it. But again, for our reproductive block, danazol has been largely replaced by leuprolide. Those are drugs that deal with Gnrh. So let's talk about drugs that deal with estrogen. You can give synthetic estrogen. We call that hormone replacement for patients that are in menopause or had their ovaries removed and they need some estrogen to avoid, hot flashes, atrophic vaginitis. So estrogen. However, why don't we give estrogen by itself? What does estrogen do to your endometrium? Causes it to grow. I feel like a broken record. I say that in every single video. Estrogen increases your endometrium. We always give it with progesterone. That kind of keeps it in check. So give with progesterone. And also another contraindication of giving just estrogen is if a patient has cancer in estrogen-dependent tissue. So tissues that respond to estrogen, that could be your endometrium, that could be your breast. So breast cancer is a big no. You don't just give estrogen in patients that had breast cancer. That's estrogen. Can we have anti-estrogens? Sure. Why would we give anti-estrogens? Well, how about in patients with estrogen-dependent cancers or patients with endometrial hyperplasia? And we want to limit that amount of estrogen. We can do that with aromatase inhibitors. Recall, androgens can get worked on by an enzyme called aromatase and become estrogen. By blocking aromatase, you block that conversion, decrease estrogen. These are drugs like letrozole. A few more drug names, they'll be in my notes. Another very important anti-estrogen you should know are called SERMs, or Selective Estrogen Receptor Modulators. They're antagonists to estrogen in some parts of your body and agonists in others. The most famous is tamoxifen, which is an antagonist in the breast. That's good if you have breast cancer. But it is an agonist in the endometrium. So what do you think that can cause? Estrogen causes growth of your endometrium. Another one is Raloxifene. Raloxifene is an antagonist to both. So you won't have side effects of endometrial hyperplasia. Know that well. It's an antagonist to both. And it's also an agonist to the bone. That is why it's used for prevention of osteoporosis. Recall estrogen inhibits osteoclasts. You can give them Raloxifene, and it is an antagonist to your breast and your endometrium, but is an agonist to your bone. That is estrogens. Let's move on to progesterones. Now, progesterone maintains your endothelium for pregnancy. So what happens if we give anti-progesterones? What do you think would happen then? These will be used for emergency contraceptives and for medical abortions. Those are your anti-progesterones, better known as mifepristone and ulipristal. Let's wrap up our video by talking about some other contraceptives. The biggest one is your OCP, or your oral contraceptive pill. And all that exogenous hormone suppresses your ovulation. That's how it works. You should know when it's contraindicated. For all the good that estrogen does, it does make you a little bit more coagulable. So contraindications include history of DVT or thromboembolic events. If they're over 35 and they smoke, because smoking also increases your coagulability. History of estrogen tissue dependent cancers like breast cancer or endometrial cancer. You don't want to grow those tissues again by giving them OCP. And migraines with aura. That's one that's commonly forgotten about, but migraines with aura is a big one. Okay, that is your OCP. We talked about a lot of drugs you shouldn't use with history of breast cancer, endometrial cancer, but for those patients that have this and desire contraceptives, what can we do? We can give non-hormonal contraceptives like copper IUD. That is an intrauterine device made of copper. And copper ions, just by their nature, causes inflammation, causes uterine changes that make it disfavorable for implantation. And it's actually very, very effective. It's one of the most effective contraceptives we have, and is also the most effective emergency contraceptive. You can go emergency or just regular contraception. And again, doesn't have any hormones, so no contraindications there. But it does have contraindications that are non-hormone related. These include things like PID or an active infection. You don't want to put it in there and make it a breeding ground for infective agents. And also it can cause PID itself because it is a device in your uterus. All right, that is your birth control. That is your menstrual cycle. Hope you enjoyed the video. See you next time.